Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confident in your exams. In today's session, we are going to break down the important features of the peritoneum into clear, high-yielding, exam-focused concepts. So let's get started. So what is peritoneum? Now peritoneum is a large, thin, serous membrane. Okay, it's a thin serous membrane which lines the interior of the abdominopelvic cavity. So this serous membrane has two layers, outer layer which is made up of fibroelastic tissue and the inner layer, okay, which is lined by the squamous epithelium. So we call it as the mesothelium. So the outer layer, it provides strength, whereas the inner layer secretes the serous fluid. So this serous membrane, so when it lines, it forms the largest serous cavity. Okay, so it is the largest serous cavity or serous sac which is present in our body. So it is the largest serous sac which is present in our body. Okay, so now these two layers. So when we see the outer layer and the inner layer. So the outer layer we call it as the outer parietal layer and the inner layer we call it as the visceral layer. So between these layers there is a potential space, okay, and this potential space is filled with the thin capillary fluid. So so here we can see, okay, so this is the peritoneal cavity lined by the peritoneum. So here we can see here, so this is the cavity and this cavity gets invaginated, okay, invaginated by the abdominal organs. And so all these organs, they are all lined by the visceral layer of the peritoneum, okay, they are all lined by the visceral layer of the peritoneum. So these organs which are suspended into this peritoneal cavity by the folds of the peritoneum. Okay, so there are various folds of the peritoneum which will suspend the abdominal organs into the cavity. When we see the folds, so based upon which organs or which structures it suspends, we have different names. Okay, and these folds, they not only suspend the organs. Now see, the abdominal organs, they do not have any bony attachments, right? So they need to be provided support by these peritoneal folds. And these organs are also attached to each other, okay, so that they are supported or they are held in the position by these folds, and these folds where they attach one to another, we call them as the ligaments, and in some places we call it as omentum also. So the fold, the peritoneal fold which will suspend the small intestine, we call it as the mesentery, which suspends the colon, okay, the transverse colon, we call it as the mesocolon, and which attaches the liver to the lesser curvature of the stomach, we call it as the lesser omentum, and along the greater curvature we see the greater omentum. And in addition to this, we also see sigmoid mesocolon where covers the sigmoid colon, right? And then we have the ligaments like gastrosplenic, gastrophrenic, okay, and phrenicocholic. So all these ligaments, they, as the name says, gastrophrenic to the stomach to the diaphragm, gastrosplenic from the stomach to the spleen, splenorenal from the spleen to the kidney. And then we have the one more, what we have, the phrenicocholic, okay, so from the diaphragm up to the left colic flexure. So all of these, they help to support or hold the organs in place. So that is the function of these peritoneal folds. And all these folds, you have to remember, they are formed by the visceral layer of the peritoneum. Okay, so they're all formed by the visceral layer of the peritoneum. So other than allowing the mobility of the organs and providing the support to these organs, these folds, they help in the transmission of nerves and blood vessels. They contain large amount of fat, and the macrophages are also present within them. Okay, the lymphatics are present within them. So all these are the functions of these peritoneal folds. So when we say omenta is plural form, singular we say omentum. So these are the peritoneal folds that connect the stomach with other organs. So we have two omenta. One is the lesser omentum, which connects stomach with the liver, and then we have the greater omentum, which connects the stomach with the transverse colon. So let's study some of the few important features of greater omentum. So now greater omentum is a large thick fold of the peritoneum. Okay, so it's a thick fold here. It is formed by 4 layers and it hangs down the greater curvature of the stomach. So basically what it does, it connects the stomach to the transverse colon. So it looks like omentum. Why we call it as omentum is, omentum means like in Latin, apron. So it looks like an apron down here, and so we call it as the omentum. So now this omentum, it attaches, okay, the greater curvature of the stomach as well to the initial portion of the duodenum, okay, that is the initial part of the first part of duodenum, and the transverse colon here. So it is made up of 4 layers. Okay, it's 4 layers of peritoneum, and they are all fused together to form a thin membrane, fenestrated membrane. And this membrane will be having a variable amount of fat. Now, the 2 layers from the lesser omentum, that is the anterior and posterior layers, which descend from the greater curvature of the stomach, okay, they extend, okay, they go down to a certain extent and then they fold on to themselves. Okay, so they go down here. So here when we see, now this is the anterior and this is the posterior layer. Now this is the lesser omentum. So here it is splitting, okay, and again they join at the greater curvature, and the 2 layers, they go down as the first and second layer. Okay, so this will be the first layer and this behind will be the second layer of the greater omentum. Now this is the greater omentum. Now then it will fold on to itself. So when it folds, the first layer becomes the 4th layer and the second layer becomes the 3rd layer. And the posterior 2 layers, when we see, they ascend up to the transverse mesocolon, where the 4th layer will loosely blend with the peritoneum on the anterior surface of the transverse colon and transverse mesocolon above it. So here a cavity is extending here, right? This cavity, this is basically the recess of the lesser sac. Okay, so here we see this space is the lesser sac. So initially in younger age and in children, we will see this extending down up to this fold of the greater omentum. But later on in adults, here it gets obliterated. Okay, so the part of the lesser sac between the second and third layer, it will get, in adults, it will get obliterated. Except for about 1 inch here or 2.5 centimeters at this part, except for this portion here, small portion here, rest of it gets obliterated. So what are the contents of this greater omentum? What does it contain? So if you see what is very glaring here, yes, it is the adipose tissue. It contains adipose tissue or fat. So an interesting fact is this amount of fat, it actually talks about the nutritional status of an individual. Okay, so depending upon the nutritional status of the individual, the fat amount will be variable. So next is also contains aggregation of macrophages. Okay, so macrophages are present here, lot of macrophages, and these macrophages we call them as the milky spots. The aggregations of it, we call it as milky spots. Other than this, near the greater curvature here, we also see the right and left gastroepiploic vessels. Okay, so the right and left gastroepiploic vessels are seen along the greater curvature. So what is the function of this greater omentum now? Now it is storing a large amount of fat. So it acts as a storage of fat. Okay, so it acts as a storehouse of fat. Then it has a large amount of macrophages, right? So what does it do? It will protect. How does it protect the peritoneal cavity? So from infections. Okay, so it protects the peritoneal cavity from infections because of the presence of the large amount of macrophages, and it will also prevent the spread of infection. So wherever there is infection or if there is a perforation, the greater omentum will move. When we say will move, it doesn't just move like that. It just moves because of the peristaltic action of the intestine. It gets moved. So these macrophages which are present there, they seal that area. Okay, so if there is a perforation and there is a leak, they will seal that area. If there is an infection, it will cover, okay, and seal that area so that the infection doesn't spread to other regions of the peritoneal cavity and infect other organs. So because of which we call this greater omentum as the policeman of the abdomen. So the greater omentum is also called the policeman of abdomen. Okay. Other than this, it is also used as a grafting material also by the surgeons. And since it is present like an apron in the anterior part of the peritoneal cavity, it will protect the underlying organs from a direct blow on the abdomen. And it forms a partition. Okay, so the greater omentum, the attachment above and below, we have the supracholic and the infracholic compartments of the greater sac. So it forms a partition. So these are some of the important functions of the greater omentum. So next, moving on to the lesser omentum. So the lesser omentum, when we see, it is in this part. So it is a double layer fold of peritoneum which is connecting the stomach to the liver. So the lesser omentum is between the lesser curvature of the stomach and the inferior surface of the liver. So inferiorly here, when we see, it is attached to the right side of the esophagus, abdominal esophagus here. Okay, so it's a small portion of abdominal esophagus, and then to the lesser curvature of the stomach, and first 2 centimeters here of the duodenum. So up to here, we see the attachment of the lesser omentum. And superiorly, it will be attached like an inverted L-shaped, okay? Inverted L-shaped, it is attached to the margins of the fissure for ligamentum venosum as well as to the porta hepatis. So along the margins of porta hepatis and ligamentum venosum, like an L-shape, inverted L-shape, it is attached above. So now this lesser omentum, it is divided into 2 parts. So based on its attachment, it is divided here into 2 parts. The part of the lesser omentum between the liver and the stomach, we call it as the 𝗖𝗵𝗺𝗃. Okay, so this portion we call it as the 𝗵𝗺𝗃 ligament. And the part between the duodenum here, okay, duodenum and the liver, we call it as the 𝗵𝗺duodenal ligament. So both of these are the parts of the lesser omentum based on its attachment and to which organ it is attached. So what does this lesser omentum contain? Okay, so what are its contents? So along the lesser curvature here, along the lesser curvature, we will see the right and left gastric vessels. Okay, right and left gastric vessels, and the lymph nodes are seen. Then we will also see the branch of left gastric nerve. Then here along the right free margin, okay, so this right free margin, it basically forms the anterior boundary of the epiploic foramen which connects the greater sac with the lesser sac. So along the right free margin here at this part, we will see the portal vein, then the hepatic artery and the bile duct. Okay, so these structures will be anterior to the portal vein. So the bile duct being anterior to the portal vein. And then this will also see the autonomic nerves and lymphatics, lymph nodes and lymphatics. Okay, so these are the contents of the lesser omentum. So next, moving on to the mesentery. So what is mesentery now? Mesentery is the fold of peritoneum attached to the small intestine, which attaches the posterior abdominal wall and the small. So next, moving on to the next fold of the peritoneum, that is mesentery. So when we say mesentery, mesentery is basically a fan shaped. So you can see here it is a fan shaped fold of peritoneum which suspends the coils of the small intestine proper, that is the jejunum and the ileum. When we say small intestine proper, it means jejunum and ileum, okay, because small intestine includes duodenum, but duodenum, most of the parts are retroperitoneal, behind the peritoneum. Only a small portion is intraperitoneal there. So that is why only the jejunum and ileum, we call them as the small intestine proper. So it suspends these coils of jejunum and ileum from the posterior abdominal wall. So this is mesentery. So the width of the mesentery, now when we see, okay, so it is thrown into a lot of folds like a frills of the frog, right? But when we see the width, it is about 6 inches. Okay, the width is about 6 inches and the maximum width in the central part is about 8 inches. Okay, this is the maximum width. So it begins. So here in the central it becomes maximum, and as it goes downwards it diminishes, okay, towards the proximal and distal ends. At both ends it is less, but in the center it is the maximum. Now when we see the mesentery, here the mesentery will show 2 borders. So one is the attached border. So this border we call it as the attached border or the root of the mesentery. And then we have the free border which is attached to the intestines here. So it is free. So this we call it as the free or the intestinal border. Free or intestinal border. Okay, so it will be basically, so when we see here, this is the intestinal, this is the free or the intestinal border which will be enclosing the small intestine. So the root of the mesentery or the attached border, right? So it is like an oblique line. So it will extend from the duodenojejunal flexure. So from this point, that is the duodenojejunal flexure. So that is to the, from the duodenojejunal flexure will be to the left of L2 vertebra. Okay, it will be on the left side of L2 vertebra. So from there it will extend up to the 𝗓𝗪𝗃𝗃 junction here. Okay, so up to 𝗓𝗪𝗃𝗃 junction. So this will be at the right sacroiliac joint. Right sacroiliac joint. So that we call it as the root of the mesentery. Okay, so this is an oblique line. Now this one, as it goes, it will be crossing few structures. Okay, so this is the border of the mesentery, that is root or the attached border, which is extending from the duodenojejunal flexure up to the 𝗓𝗪𝗃𝗃 junction, that is from the left of L2 vertebrae up to the right sacroiliac joint. So as it is crossing here, you can see it is crossing many structures, right? So to remember the structures, how to remember them easily is remember HAIR, hair, okay? So hair 3. So there are 3 R's, so hair 3R. So what is H now? The horizontal part of the duodenum, okay? So the horizontal, that is the third part of duodenum. Horizontal part of duodenum. Then what do we see? A is for abdominal aorta. Now in anatomy, when you make mnemonics also, it is better to make the mnemonic in a way the structures are present in the body, like the anatomical arrangement, whether it is medial to lateral, anterior to posterior. So that it becomes easier to recall and you know which lies medially, which lies laterally, the way you will say the structures. So that is why here I have given this mnemonic for you. The horizontal part of duodenum is the H, A is the abdominal aorta, and I is the inferior vena cava, and the 3 R's. So which are the 3 R's? If you see here, first will be the right gonadal vessels. Okay, the second R is, we have the ureter, you can see, right ureter. and the right psoas major. So these are the structures which are crossed by the root of the mesentery. Next is the free border or the intestinal border. Now this free border, right, it is about 6 meters. Okay, it is almost about 20 feet in length. And it will be enclosing the jejunum and the ileum. So that is the free border. So the root of the, so if you see, root of the mesentery is about 6 inches long in the periphery, whereas the free border is about 6 meters. So because of that, what happens is, to accommodate, it will throw itself into folds like the frills of a frog. So why is this length? Why does it require such a big length? Because it permits the movement, okay, permits the free mobility of the loops of jejunum and ileum during the peristalsis movement, right? It facilitates the free movement. And this mesentery now, okay, so what are the contents of the mesentery? So the mesentery here, right, so the mesentery will be having the superior mesenteric vessels. So within the mesentery, we have the superior mesenteric vessels, which gives the jejunal and ileal branches, supplying the jejunum and ileum also. And then we see lymphatics, which we call it as lacteals. Lacteals we are seeing here. Large amount of lymph nodes and fat. Okay, fat is also present there. And because it encloses the jejunum and ileum. So they are the contents which is present within the mesentery. Now here we have to observe that the distribution of the fat, okay, so in the jejunal region it is less, whereas as we go towards the ileum, the fat is more within the mesentery. Okay, so here near the jejunum, now this is the jejunum and here we have the ileum. So this is jejunum and this is the ileum. So when we see here in the jejunum now, the jejunal arteries, okay, when they form arcades, and from these arterial arcades, the vasa recti will begin and they supply the jejunum. So now here we'll see lesser number of arcades and the vasa recti will be very longer here, okay. And between these vasa recti, the mesentery will be having small amount of fat. But here since the fat is less, it is very translucent. So we call them as translucent peritoneal windows. So translucent peritoneal windows. Whereas as we go towards the ileum, the arterial arcades are more, the vasa recti are shorter, and between those, the mesentery which is present between these vasa recti, right, will have more amount of fat. And because of which here the peritoneal windows is basically the peritoneum present between the vasa recti. So here the peritoneal windows will be opaque, okay, opaque windows. So that was about the peritoneal folds. Next we move on to the peritoneum cavity. Now the peritoneal cavity, when we see, it is the largest and a very complex serous sac in the body. Okay, it's the largest and the complex serous sac in our body. So this peritoneal cavity is basically the potential space between the visceral and the parietal layer of the peritoneum. So now in males, this peritoneal cavity, it is a closed sac. Okay, it is a closed sac. It will not make any communications with the pelvis, with the lesser pelvic structures. Okay, it doesn't have any communication there. But whereas in the females, through the pelvic ostia, okay, the ovaries and the fallopian tubes, they have the communication to the peritoneal cavity. So in females, that is why in females we say, okay, in females it is an open sac because of the communication, and in males it is a closed sac. So because of this reason, the pelvic infections, okay, because of that the pelvic infections can spread to the peritoneal cavity through that pelvic ostia in females. So what is the function of this peritoneal cavity now? Now between these two layers there is a thin amount of capillary fluid. So that helps in the lubrication. Okay, it provides a slippery surface for the free movements of the abdominal viscera. It prevents the friction between the two layers as they move. Then lubrication, so mainly lubrication. Then it guards the viscera, protects the viscera against any infection. Okay, peritoneum contains large amount of phagocytic cells within its mesothelial lining, and it will protect the viscera. Then prevents the spread of infection. Okay, prevents the spread of infection, just like how we saw the omentum sealing the infection site, right? So that is how it will prevent the spread of infection. And it will also provide a large surface area for the absorption. For the absorption of fluid. Okay, so for the absorption it provides a large surface area. And it will provide healing power. Healing power to what? To the mesothelial cells. Okay, how? It can transform them into fibroblasts. Okay, so fibroblasts are necessary for the formation of the collagen fibers. So thus it will help. And then it provides storage of fat. Okay, provides for the fat storage. So all these things are the functions of the peritoneal cavity. So now this peritoneal cavity, okay, is further divided. So you have to imagine a large bag, okay, a shopping bag, which will have a small pocket inside, right? You might have seen that big bag with a small pocket where you keep the coins. So it is something like this. Okay, so it has a large sac and it is divided into two sacs. Okay, so it is divided into two compartments. One is the greater sac. Behind is the lesser sac. So the greater sac, if you see, it is the largest compartment. It's that large compartment of the bag, okay, and extends across the whole breadth and length of the abdomen. So the entire whatever, when you open the peritoneal cavity, whatever you see, that is the greater sac. The moment you open the parietal peritoneal layer, right, the entire thing what you see will be the greater sac. And when you peep through the stomach, okay, that is you go behind the lesser omentum and see behind that portion will be the lesser sac, smaller compartment which lies behind the, so basically in the upper part, right, we have this liver, the stomach, and in those portions behind we will see the lesser sac. So these two will be communicating. So we saw when we studied the lesser omentum, so it has a right free margin, that is where it forms the anterior boundary of epiploic foramen. So through that foramen, the greater sac will be communicating with the lesser sac. So that is about the subdivisions. So when I told you earlier, the peritoneum is a closed sac in male and a open sac in females. So when we trace the peritoneum in males in the lower part, right, here we can see the peritoneum covering the anterior part of the rectum. Okay, so it will cover the upper 1/3. In the upper 1/3, it covers the anterior and lateral sides of the rectum. In the middle 1/3, it will cover only the anterior, and in the lower 1/3, we do not see the peritoneum covering the rectum. So from this middle part here where it covers, it will reflect onto the superior surface of the bladder, and then it becomes continuous with this parietal layer here. Okay, so in the anterior and forms part of the anterior abdominal wall. So this is the reflection. So here we see a pouch. This pouch we call it, that is between the rectum and the bladder, we call it as the rectovesical pouch. So this is, we see it in males. Okay, so this is in males. So here in the females when we see, in the females we see the peritoneum is a open sac because there is a small opening here, the pelvic ostia, through which the fallopian tube. So you can see the fallopian tube, the ovary here, the ovary and the fallopian tube communicating here into the peritoneal cavity. So when the peritoneum reflects onto here, it reflects onto the rectum just like as in males, and then onto the cervix as well as the posterior surface of the uterus, onto the fundus, and then onto the superior surface of the bladder, and becomes continuous in the front with the parietal peritoneum. So here we will see two pouches, okay. So one is the rectouterine pouch, of Douglas, and other one is the rectovesical pouch. So these two pouches we see, and this rectouterine pouch of Douglas is the most dependent part, okay, dependent part in a semi-horizontal position. It is the most dependent part in females. So any infection, it gets collected in that pouch. So this is about the peritoneal covering the peritoneal reflection in males and females. So now let's move on to the subdivisions. Okay, so the peritoneum is divided into two cavities, the greater and the lesser, right? So we have the greater sac here and the lesser sac behind. So first we'll study about the greater sac. So the greater sac, it is the main part of the peritoneal cavity, into which all the organs will just protrude, okay. So all the organs will be protrude, all the peritoneal organs will be seen here in the greater sac. So this cavity, okay, the greater sac cavity is divided into a supracholic and infracholic compartment by the attachment of the mesocolon, the transverse mesocolon, and its mesentery, that is the transverse mesocolon. So above the attachment of that is the supracholic compartment, and below the attachment of the transverse mesocolon and transverse colon we have the infracholic compartment, okay. So this becomes the supracholic and this is the infracholic compartment. Okay, so when we see from the front, this will be the, so this is the point of demarcation here. So above this is the supracholic and this is the infracholic. So supracholic is large, okay, large compartment, and it is under the cover of the diaphragm as well as costal margin and the diaphragm. So that entire part will be the supracholic compartment. And infracholic compartment here, okay, so infracholic compartment is filled with the basically the coils of the jejunum and ileum. So those we will see here, and it is surrounded here. You can see the ascending colon, the transverse colon, and the descending colon are seen all around this infracholic compartment. So this infracholic compartment again is further divided by the, okay, so by the root of, this is the root of the mesentery here. So the root of the mesentery will divide the infracholic. Root of the mesentery is going to divide the infracholic compartment into two parts, that is a right infracholic and a left infracholic. So the right infracholic, if you see, it is triangular, okay, it will be triangular, whereas this is quadrangular, okay. So this is like a quadrangular in shape. So the apex of this right infracholic compartment, since it is triangular, the apex will be just at the iliacecal junction, just below the iliacecal junction. So if you see, it is bounded on the right side by the ascending colon, above by the transverse colon, and on the left side by the root of the mesentery. So that is its boundaries, and the left infracholic space here is larger than the right one, and it is, as I said, it is quadrangular in shape. So this is bounded by the transverse colon, okay, above, and on the right side by the root of the mesentery above transverse colon, and on the left side by the descending colon, inferiorly by the sigmoid colon here, okay. And below here, if you see, it becomes continuous with the pelvic brim. So it is not an open sac, just it extends there, okay, it extends up to the pelvic brim. So on the sides of the ascending colon and the descending colon, we see two gutters, okay. So this we call it as the right paracolic gutter paracolic gutter, and this we call it as the left paracolic gutter. So this right paracolic gutter will be continuous above with the hepatorenal pouch of Morrison. Okay, so these communications are important so as to understand how the infection in the peritoneum can spread from one region to another. So next, moving on to the subphrenic spaces. Okay, subphrenic spaces. So when we say subphrenic spaces, it is the spaces below the diaphragm. So now in this, that is below the diaphragm, we see 6 spaces. Okay, 6 spaces are in relation to the diaphragm, that is below the diaphragm, and in relation to the periphery of the liver. So these spaces are important because the pus collects in these spaces, forming the subphrenic abscesses. So subphrenic abscesses are common in these spaces, especially there are 2 spaces where we see more common the infections. Okay, so pus can be collected there in these spaces, leading to subphrenic abscesses. So now among the 6 spaces, what you have to know is there are 3 spaces on the right side and 3 spaces on the left side, 3 on the right and 3 on the left. And among the 3 on the right and 3 on the left, okay, 2 are intraperitoneal, and 1 extraperitoneal. Okay, same thing on the left also, true intraperitoneal and 1 extraperitoneal. So now we will see which are those 6 spaces, 6 subphrenic spaces on the right side and on the left side. So here on the right side, we have, see, 1 is extraperitoneal and 2 are intraperitoneal. So we have on the right side, we have the right posterior intraperitoneal and right anterior intraperitoneal and right extraperitoneal. Okay, so 1, 2 and 3. Similarly, on the left side, we have the left posterior intraperitoneal, left anterior intraperitoneal and left extraperitoneal. So these are the 6 spaces, subphrenic spaces which see. And now we will see among these 2 important spaces. So one is the right posterior intraperitoneal compartment. Another one we will be studying the left posterior. So these posterior intraperitoneal compartments on the right and on the left, both are very important clinically. So the right posterior intraperitoneal compartment is called as the hepatorenal pouch of Morrison, and the left posterior intraperitoneal compartment is our lesser sac or the omental bursa. So first coming to the right posterior intraperitoneal compartment. So here this is situated. So where is it located now? Here if you see, it is located between the posterior-inferior surface. Okay, so this is the posterior-inferior surface of the liver and in front of the right kidney. So this is the hepatorenal pouch of Morrison or Morrison's pouch. Okay, so Morrison, hepatorenal pouch of Morrison. So this is, okay, posterior inferior surface of liver and in front of the right kidney. So now here if we see the boundaries, so boundaries anteriorly the posterior inferior surface or the visceral surface of the liver. Posteriorly it is the peritoneum here which is covering the surface of the anterior surface of the right kidney, basically the upper pole region of the right kidney as well as the diaphragm it covers. And above it is the, here it is limited, okay, it is limited by the coronary ligament. And below it is limited by the transverse colon and the transverse mesocolon. Transverse colon and transverse mesocolon. Okay. So that is the boundaries of the hepatorenal pouch of Morrison. Now this Okay, so this is the most dependent part in the supine. So in the supine position, the hepatorenal pouch of Morrison is the most dependent part. So any pus gets collected in this region. Okay, so here now the infection can spread to other regions. How it can spread is because of its communication. So it communicates on the left. Okay, on the left it will communicate through the foramen epiploicum or the epiploic foramen with the lesser sac. That is, lesser sac is nothing but the left posterior intraperitoneal compartment. Okay, so it will communicate to that through the epiploic foramen, and from which the infection can spread. And along the sharp inferior margin of the liver, okay, along this it communicates with the right. So from right anterior. So from posterior to anterior it communicates, and from the right posterior to left posterior it communicates. So that is its communication. Next, the right posterior intraperitoneal compartment, which is otherwise known as the lesser sac or omental bursa. So this is the diverticulum of the peritoneum, which we see behind the stomach and the liver. Okay, so this portion. So it communicates to the greater sac. How? Through the epiploic foramen, it will be communicating with the greater sac. So this epiploic foramen is otherwise also called as foramen of Winslow. So now when we see this, this is the epiploic foramen here. Okay, or the foramen of Winslow. So this lesser sac is basically behind the stomach. What we are seeing here is the greater sac. So it will be communicating through this foramen with the greater sac, that is the lesser sac. So when we see the boundaries here, now this is our space, left posterior intraperitoneal compartment or lesser sac. So when we see here, okay, anterior wall. Okay, so the anterior wall of it is formed from here. If we come, okay, we have the caudate lobe of the liver, caudate lobe, then we'll have the lesser omentum, then we have the posterior-inferior surface of stomach and the anterior two layers of greater omentum. Considering the lesser sac will be extending between the layers of the greater omentum. So posterior wall. So this is the anterior wall of the lesser sac, and posterior wall when we see here. So the posterior wall is formed when we go from below upwards, it is formed by the posterior two layers of greater omentum and the structures forming the stomach bed. So here basically we will see the transverse colon, the transverse mesocolon here. Okay, the transverse colon and the transverse colon and transverse mesocolon, and then we have the pancreas. Okay, so in this region we will have the pancreas, then upper part of the left kidney, okay, left kidney and left suprarenal gland, and the diaphragm here. This is the diaphragm. So all of these, they form except for the spleen, all these structures will form which form the stomach bed will be forming the posterior wall of the lesser sac. So now to recollect the boundaries here. So when we see the lesser sac, the anterior wall, it is formed by the caudate lobe of the liver. Then we have caudate lobe of the liver, then the lesser omentum, the stomach, the posterior inferior surface of stomach, and then we have the anterior two layers of the greater omentum. And as we come, same way the posterior wall, if we trace from below upwards, we have the greater omentum, the posterior two layers, the transverse colon and the transverse mesocolon, transverse colon and transverse mesocolon, and then we have the pancreas, the anterior surface of the left kidney, and the left suprarenal gland, and then in the upper part we'll have the diaphragm. So these will form the posterior wall of the lesser sac. So this lesser sac in children, okay, and in young age, we will see the lesser sac extending between the anterior 2 and posterior 2 layers of the greater omentum. Now this is the greater omentum. So it will be extending up to this fold here of the greater omentum. But as age advances in adults, the layers of the greater omentum, they fuse, and because of which what happens is this lesser sac is obliterated here. Okay, the lesser sac is obliterated except for the upper 2.5 centimeters or about an inch of here. Okay, only up to just behind the stomach it will extend up to about 2.5 centimeters or about an inch. So it will be restricted only to this portion of the stomach. So this is the lesser sac. So the lesser sac presents few recesses, that is, it basically extends a little bit beyond, and that is superiorly, inferiorly, as well as on the left side, and those out pouches which are formed, we call it as the recesses. So we have 3 recesses of the lesser sac. So lesser sac is basically like, if you see, it is like a hot bag, okay, hot water bag with its neck facing to the right. Okay, so this will be the neck which is facing to the right side. So this is the bag. Okay, so it is something which you can compare it to the hot water bag. Now this will have its extension superiorly, which we call it as superior recess, then inferiorly, that is inferior recess. Okay, so superior, inferior, and splenic, that is towards the left. So the superior recess lies behind the liver and the lesser omentum. Okay, so that portion we call it as the vestibule of the lesser sac. The portion behind the lesser omentum we call it as the vestibule of lesser sac. So this is the superior recess. Inferior recess is the portion which lies between the anterior 2 and posterior 2 layers of greater omentum. So this is the inferior recess. And then we have the splenic recess. So splenic recess will be lying between the gastrosplenic and the lienorenal ligaments, between the gastrosplenic and lienorenal ligaments. So these are the 3 recesses of the lesser sac. Okay, the superior recess behind the liver and the lesser omentum, the inferior recess between the anterior 2 and the posterior 2 layers of the greater omentum, and the splenic recess between the lienorenal, that is from the spleen to the kidney, and the stomach to the spleen. Okay, so between that's space, right? That is the splenic recess. Next, a little bit about the epiploic foramen. So epiploic foramen is also called as the foramen of Winslow. Epiploic foramen is also called as the foramen of Winslow. So this epiploic foramen, when we see here, it is a vertical slit which we can see, and through which the lesser sac and the greater sac will be communicating. So this is situated behind the right free margin. This is the lesser omentum. So it is situated behind the right free margin of the lesser omentum. So coming to the boundaries of the epiploic foramen, anteriorly, okay, so anterior is here. So this is the anterior boundary. So anterior boundary is formed by the right free margin of the lesser omentum containing these 3 structures. That is, we have the portal vein, the hepatic artery, and the bile duct. So the hepatic artery and the bile duct will be anterior to the portal vein, and the duct will be dexter, that is right of hepatic artery, to the right of hepatic artery. So that is what we see on the anterior boundary. Then when we come to so it is the free margin of, right free margin of lesser omentum. Posteriorly, we see the inferior vena cava. Okay, so posteriorly we see the inferior vena cava, And superiorly here when we see the caudate lobe of the liver. Superior caudate lobe of the liver. And inferiorly here will be the first part of the duodenum. In this portion, we'll have the first part of inferiorly, first part of duodenum. This is inferior relation. So, these are the inferior, all the four boundaries, anterior, posterior, superior and inferior boundary of the epiploic foramen. So, abscesses in the subphrenic spaces are very common, especially in the hepatorenal pouch of Morrison and the lesser sac. Okay, so infection can spread from one space to the other because they communicate. That is from the right posterior intraperitoneal to the left posterior intraperitoneal through the epiploic foramen. It can communicate, and also it can go down. That is from the Morrison's pouch to the right paracollic gutter also the infection can go down. Okay, so that is how the abscesses can spread from one compartment to the other. So we can see here. Now this is the supracolic. So this was the supracolic compartment. This is the infracolic compartment, okay, of the peritoneal cavity. So this was the attachment of the transverse mesocolon here. So above that is the supracolic, below is infracolic. This is the right paracollic gutter. This is the left paracollic gutter. Right and left paracollic gutter. Okay, so and then here we have the subphrenic spaces. So behind the liver here will be the hepatorenal pouch of Morrison or Morrison's pouch. And here like this, here we will see this will be the lesser sac. Okay, so here it will be the posterior extraperitoneal compartment. So here if you see now, so infection, see from the paracollic gutter it can go up to the Morrison's pouch, or from here it can come down here, and from the Morrison's pouch to the lesser sac. Okay, and here also it can go from the left paracollic gutter here behind to the extraperitoneal compartment, or down because there it will be extending up to the region of the pelvic brim, right? So it can go up to there. Here also this infracolic compartment we divide by this root of mesentery into the right and left infracolic compartment, right? So from here also it can go up to the pelvis. Okay, so the infection can reach up to there. So if there is any collection of pus, it can collect in the most dependent region. So this is the rectouterine pouch of Douglas. Okay, so rectouterine pouch of Douglas here. And this pouch of peritoneum is located between the rectum and this. So this is the pouch. Okay, pouch of Douglas. So it is the most dependent part of the peritoneal cavity in upright position in females. Okay, so in the upright position, it is the most dependent part, and in the supine position, it is the most dependent part in the pelvis. So upright part, when you are straight, of course, that will be the most dependent part, and in the supine stage, in the pelvis, that will be the most dependent part. So when we see the boundaries here, anteriorly bounded by the uterus as well as the upper 1/3 of the vagina, that is the posterior fornix of vagina here. Posteriorly, it is bounded by the rectum. Okay, posteriorly it is bounded by the rectum here. Here we have the anteriorly the uterus and the posterior fornix of vagina. Inferiorly, the floor is formed by the rectovaginal fold here, that is the fold of the peritoneum which is reflecting on here. And this floor, right, it is about 5.5 centimeters above the perineal skin. Okay, so from here, if we see, the pouch will be, so this will be the perineal skin. So from here to here, the distance will be at about 5.5 centimeters. So since it is the most dependent part of the peritoneal cavity below the pelvic brim, the pus tends to collect there, okay, from the pelvic and form the pelvic abscess. So it can be drained by colposcopy, okay. through the posterior fornix of the vagina, which we call it as the colpotomy. So colposcope is the instrument used to see. Colpotomy is the procedure which we do to drain the pus from this pouch. So you can see this is the most dependent part in the pelvis and the site of pelvic abscess. So when we say 𝗙𝗪scope is basically an instrument which is inserted through the posterior part of the vaginal fornix to examine the ovaries or uterine tubes in case if there is a suspicion of tubal pregnancy, we do that. Nowadays, we use laparoscopy instead of a 𝗙𝗪scope. And 𝗙𝗪centesis is the procedure, that is posterior colpotomy or 𝗙𝗪centesis we do, where the pelvic abscess or fluid or blood in the rectouterine pouch here can be drained through an incision made in the posterior fornix of the vagina. So from there it can be drained. So that is known as 𝗙𝗪centesis. So when we can see here, see this is the most dependent part. So in the supine position, the hepatorenal pouch is this is the pouch of Morrison. It is the most dependent, and in the pelvis, the pouch of Douglas. So pouch of Douglas, we see it in only females. So they become the dependent part where the pus can get collected and form the abscess. So peritonitis. So what is peritonitis? Peritonitis is basically the inflammation. Itis is inflammation. So when the peritoneum is infected and there is inflammation, signs of inflammation, we call it as peritonitis. In peritonitis, we see severe rigidity, okay, and pain around the site of infection and tenderness. And this rigidity, we call it as the cardboard, okay, cardboard rigidity. When we palpate, right, the abdomen will be very rigid. It's basically as a reflex action where because of the pain, okay, the patient tends to just keep the muscles tight there, okay. So that is cardboard type of rigidity. And when we try to auscultate for the intestinal sounds will be absent. So pressure applied to the abdominal wall. Okay, if there is a infection at a particular site, and if we if we apply pressure, okay, with the finger over the site of inflammation, and suddenly when we remove the hand or the finger, it will cause tenderness, okay, at the local, or the pain will increase at the local site of infection, and that is called as the rebound tenderness. So collection of fluid in the peritoneal cavity increase. So there is minimal amount of fluid between the two layers of peritoneal cavity so as to lubricate and prevent friction, right? But when there is excessive collection of fluid, we call it as ascites. Okay, so ascites is basically excessive collection of the fluid within the peritoneal cavity. So now if there is blood, we call it as hemoperitoneum, and if there is air, we call it as pneumoperitoneum. So here now in ascites, when we do the peritoneal tap, okay, or when we remove the fluid, the procedure of removing the fluid from the peritoneal cavity, okay, or draining the fluid from the peritoneal cavity, we call it as the paracentesis abdominis. Paracentesis abdominis. So it is a procedure by which the excess fluid which is collected in the peritoneal cavity is evacuated, or it is removed by inserting a cannula. So now here, while we are removing, okay, we need to know where exactly we need to put the cannula, right? So what do? We do after emptying the urinary bladder with the catheter, okay. So we put a catheter, empty the urinary bladder, and then the cannula or the trocar is inserted or introduced through either through the anterior midline where the linea alba is relatively bloodless, okay. So linea alba, we know that it is basically a fibrous raphe, so the blood vessels are less in that region, so we can directly put through the anterior abdomen, that is through the midline, we can put the trocar, okay, or through the lateral flanks, okay. So here in the laterally we can put. especially lateral to the McBurney's point. So here where we have the McBurney's point at the junction of the lateral 1/3 and the medial 2/3, we'll have the McBurney's point. So lateral to that, if we insert the trocar, okay, we are less likely to injure the inferior epigastric. This is the inferior epigastric artery, and we are less likely to injure this artery. Okay, so we usually use these regions to put the trocar or the cannula. So when we are inserting, when we are passing the cannula through the flank, okay, what are the structures we are going to encounter? So we will meet all the layers of the anterior abdominal wall. That is the skin, the superficial fascia, then the aponeurosis of external oblique, then the internal oblique muscle, the transverse abdominis muscle, then there is fascia transversalis, a small amount of extraperitoneal tissue, and the parietal layer of peritoneum. So after that we reach the peritoneal cavity, right? So this is the structure. So here you have to remember the anterior abdominal wall doesn't have the deep fascia. We do not encounter the deep fascia. So pneumoperitoneum is basically air-filled peritoneal cavity. So perforation of stomach or intestine can cause this condition, and we can see the air collected here under the right dome of right diaphragm. This is how we will see in an X-ray. So here the peritoneum is the site where we can perform peritoneal dialysis as well as a VP shunt procedure is also performed. Now in VP shunt, we usually do it hydrocephalus. So a catheter is placed in the ventricles and it is allowed to drain. Okay, the catheter is passed subcutaneously and then that is to the scalp and then behind the ear and then through the neck and into the thoracic cavity, and from there, like it is drained into the through the thorax. It goes subcutaneous and then it is drained into the peritoneal cavity. Okay, so that excess of CSF which is produced in hydrocephalus and which cannot be absorbed due to maybe obstructive conditions, in those cases it is allowed to drain into the peritoneal cavity. So that is VP shunt. In peritoneal dialysis, okay, so here we know that the peritoneum is a semi-permeable membrane and it has a wide that is extensive surface area, much of which it covers the large amount of blood vessels and lymphatics. So there is always an exchange of the solutes, okay, between the blood and the peritoneal cavity here. So what we do here is in chronic renal failure. So in chronic renal failure, a dialysate fluid, okay, is filled into the peritoneal cavity. It is allowed to dwell there for some time, and when all the waste products are removed, then it is drained. Okay, so first dialysate fluid, this is the dialysate. So it is filled into the peritoneal cavity and then allowed to dwell there and then it is drained. Okay, so fill, dwell, drain. So this is what is done in the peritoneal dialysis. Then the referred pain of organs. Okay, so the visceral pain can be referred to the different parts of a body because of the same spinal segment innervation. So for example, the appendicular pain is felt around the umbilicus. The gallbladder pain is felt around the tip of the shoulders. Okay, and the cardiac pain sometimes behind the retrosternum. So this is all because of radiating along the left arm. This is all because of the same spinal nerve or the spinal segment which supplies the viscera as well as that part of the skin. So coming to some of the image-based MCQs, in a diagram showing the peritoneal cavity, a space between the liver and the right kidney. Okay, so between the liver and the right kidney, we have the hepatorenal pouch of Morrison. Okay, the hepatorenal. So C is the right answer. A diagram shows a fold extending from the liver to the lesser curvature of the stomach. It is basically the lesser omentum. If they give the parts of the lesser omentum, okay, so from the liver to the greater curvature of the stomach, we call it as the 𝗕𝗵𝗄𝗏gastric ligament. In laparoscopic view, a window behind the stomach is seen. So what is the window behind the stomach? It is the lesser sac. And that's a wrap on today's session on the peritoneum. So stay consistent with the series as they bring you one step closer to your NEET PG dreams. So stay consistent, stay focused, trust in your preparation. I will see you in the next session.